tel que
earlier
le nombre
indicators like
quotidien des
daily
cas
case counts
soit
are now
actuellement
strikingly
extrêmement
high,
élevé et que le nombre réel de nouvelles
while at the
infections
same
soit
time
considérablement
significantly
sous-estimé, la
underestimating the
présente
true
séance
number
est
of new
plutôt axée sur
infections.
d'autres
This
indicateurs
update
qui
puts more
demeurent utiles
emphasis
à
on
la
some of the many
surveillance des
other
tendances
indicators
et à
that
la
continue
prévision
to be
des
useful
trajectoires
for
à long
monitoring
terme.
current trends and predicting longer range
Slide
trajectories.
1. Since the last epidemiology and modeling update in December, despite being underestimated, current national case counts of over 37,500 new cases reported daily are far exceeding all previous peaks of the pandemic. The sudden spike in Omicron infections has daily case counts now trending far above the daily counts for severe outcomes. And while international surveillance shows that severity trends do not rise at the same explosive rate as cases, the record high volume of cases associated with the Omicron surge is nevertheless expected to heavily impact hospitals. Although there are likely to be continued challenges before we hope to see improvement, caution and perseverance will help to get us through this difficult period sooner and mitigate the impacts on our severely strained health system.
Diapositive 2. Avec des taux
Slide
d'infection
2.
très élevés qui
With
défient
very
ou dépassent
high
les capacités de
infection
dépistage
rates
dans une grande partie
that are
du pays,
challenging or
un
exceeding testing
éventail
capacity across
d'autres
much of the
indicateurs
country, a range
tels
of
que la
other
positivité
indicators
des
such as
tests de
laboratory
laboratoire sont utiles
positivity
pour
are
surveiller
useful for
l'activité
monitoring
de la
disease
maladie
activity
au
at the
niveau
population
de la
level.
population. Actuellement, le pourcentage de
Currently,
positivité
laboratory
des tests
test
de laboratoire
positivity
est de
is
28%,
28%,
signifiant que le virus
meaning
est
more
détecté
than 1
dans
in
plus d'un
4
test sur 4.
tests are
Bien que
positive
de
for the
nombreuses
virus.
juridictions accordent la
Although
priorité de
many
dépistage
jurisdictions
aux
have
personnes et
prioritized
aux
testing to
populations les
individuals
plus
and
à risque de
populations at
maladies
higher
graves
risk of
ou
severe
d'exposition,
outcomes or
le taux de
exposure,
positivité très élevé
the
actuel montre que la
very
COVID-19
high
s'est
positivity rate
largement
shows that
propagée
COVID-19
et
is
que le nombre de
widespread
cas
and that case counts
sous-estime le
underestimate the
véritable
true
fardeau de
burden of
l'infection
infection
dans la
in the
population en
broader
général.
population.
Néanmoins, le suivi de la
Nevertheless,
tendance
tracking
en
the
ce qui
trend of this
concerne cet
indicator can
indicateur
help
peut
tell
nous
us
aider à
whether
déterminer
COVID-19
si la
disease
COVID-19
activity
demeure
remains
très répandue
widespread or is
ou si elle
beginning to
commence à
decline in
s'affaiblir dans
areas of
certaines
the
régions
country.
du pays. En même temps,
At the same
d'autres
time, other
indicateurs
indicators
continuent
continue
d'être
to be used
utilisés
in
en
parallel to
parallèle
monitor
pour
other
surveiller
aspects,
d'autres
including
aspects,
patterns of
notamment les
disease
tendances en
severity.
matière de gravité de la maladie.
Slide 3. That Omicron is the most contagious variant observed to date is evident from these curves, showing the sudden increase in the proportion of cases due to Omicron shown by the red curve on the right. First reported in Canada in late November, Omicron has rapidly replaced Delta to become the predominant variant circulating in Canada as of mid-December.
Diapositive 4.
Slide 4.
Les tendances liées aux hospitalisations sont indiquées pour les 6 provinces canadiennes les plus populeuses, mais contrairement aux vagues précédentes de la pandémie, pendant lesquelles la propagation de la maladie était généralement bien maîtrisée dans certaines juridictions plus petites, la hausse des cas attribuables au variant Omicron est généralisée au pays. Bien que les données indiquent que le risque d'hospitalisation est plus faible pour le variant Omicron que pour le Delta, des cas de maladies graves surviennent toujours avec Omicron et les répercussions sur les systèmes de santé et d'autres secteurs peuvent être substantielles. Ceci s'explique par la hausse des hospitalisations et des admissions aux soins intensifs, ainsi que par l'augmentation du nombre d'employés malades et devant s'isoler. Déjà, le nombre énorme de cas a commencé à stimuler une augmentation des tendances de cas de maladies graves à l'échelle nationale. Ces augmentations sont plus évidentes en Ontario et au Québec, qui ont été les premiers à connaître la poussée d'Omicron, mais la plupart des régions du pays commencent à voir ou devraient s'attendre à voir de fortes augmentations de nombre quotidien d'hospitalisation au cours des prochaines semaines. Depuis notre dernière mise à jour, le nombre de personnes atteintes de la COVID-19 traitées dans nos hôpitaux a plus que quadruplé pour atteindre une moyenne de plus de 6 779 hospitalisations par jour
while the
tandis que le
number
nombre
of
de
people in
personnes se
critical
trouvant
care
aux
has
soins
doubled
intensifs
to an
a doublé
average
pour atteindre
of
une
over
moyenne de plus de
884
884 par jour
daily
et
cases,
82
and
décès ont
82
été
deaths
signalés
were being
quotidiennement.
reported daily.
Maintenir les taux d'infection à
Keeping
de faibles
infection
niveaux
rates
reste
down maintains
essentiel
key to
afin
mitigating the
d'atténuer
rise in
l'augmentation
severe
des
illness
tendances de
trends
maladies graves
as much
autant
as
que possible
possible
au cours
over
des
the coming
prochaines
weeks.
semaines.
Slide 5. The incidence of reported cases is higher across all age groups than at any time previously during the pandemic, as opposed to previous weeks when rates were highest among 5 to 11-year-olds who were just becoming eligible for vaccination. Incidence rates are currently highest among adults aged 20 to 39 years. With Omicron's greater ability to evade prior immunity from infection and vaccines, cases are now increasing in all age groups.
Diapositive 6.
Slide 6.
Bien que le nombre global de cas entraîne une hausse des taux d'hospitalisation dans tous les groupes d'âge, la répartition par âge des cas hospitalisés est similaire aux vagues précédentes de la pandémie, avec les taux d'hospitalisation les plus élevés étant observés chez les Canadiens plus âgés. Au cours des derniers mois, les cas de maladies graves, y compris le nombre d'hospitalisations et d'admissions aux soins intensifs, ont été les plus importants chez les adultes de 60 ans et plus, et particulièrement chez eux de 80 ans et plus. En fin de compte, l'impact à l'échelle de la population dépendra du nombre global de cas entraînant une maladie grave. Donc, tout ce que nous pouvons faire pour ralentir la propagation contribue à atténuer l'impact individuel et collectif. Chez les groupes d'âge plus jeunes, les cas parmi les nourrissons âgés de moins d'1 an sont presque 7 fois plus susceptibles d'être hospitalisés que les enfants âgés d'1 à 4 ans. Mais, bien que le nombre d'hospitalisations ait augmenté chez les enfants comparativement aux vagues précédentes, il demeure faible dans l'ensemble, représentant moins de 1% des cas signalés chez les enfants de moins de 5 ans. Heureusement, chez les enfants, les taux d'admission en soins intensifs continuent d'être faibles. Néanmoins, en maintenant les taux d'infection les plus bas que possible, nous pouvons réduire le nombre de maladies graves chez les enfants.
Slide 7. Omicron's rapid rate of spread is likely due to a combination of inherent characteristics of the virus that makes it more transmissible and increased ability to evade prior immunity from past infection and vaccination. Similarly, Omicron's lower severity profile, as seen in international and Canadian data, is likely due to characteristics of the virus and protection from severe disease as a result of vaccination and/or prior infection. This is supported by the fact that those with 2 doses of vaccine are less likely to be admitted to hospital, and this protection is increased with an additional mRNA vaccine dose of either Moderna or Pfizer COVID-19 vaccines. While considerably lower proportion of Omicron cases are being hospitalized compared to Delta, severe illness does occur with Omicron, and the impact on the health system and other sectors is expected to be substantial. Hence, vaccination, including getting an mRNA booster dose as eligible, continues to be important in combination with timed and targeted public health measures and individual protective practices for slowing COVID-19 infection rates and help to reduce impact on healthcare capacity. As well, despite a high number of outbreaks being reported in long-term care homes and seniors' residences, preliminary evidence indicates that these outbreaks are associated with less severe illness and the number of deaths remains low. However, as seen with hospital outbreaks, these outbreaks can involve a high number of cases among staff, which is contributing to reduced staffing levels.
Diapositive 8.
Slide
En tout,
8.
plus que 72 millions de
more
doses
than
de vaccins
72
contre le
million doses
COVID-19
of
ont
COVID-19
été
vaccines have
administrés
been
au Canada
administered across
depuis le
Canada
début
since
de la
vaccination
vaccination
began
à la
in
mi-décembre
mid-December
2020.
2020.
Cependant, bien que les Canadiens
While
âgés de
Canadians
12 ans
aged
et
12
plus
years
ont
or
eu une
older
couverture
have
vaccinale
over
de plus de
83%
83%,
vaccine coverage
ayant
with
reçu
at
au moins
least
2
2
doses de
doses,
vaccin, La couverture
Coverage is
est beaucoup
lower
plus faible
among
chez les enfants
5
âgés
to
de
11
5 à
year olds
11 ans qui
who
sont
more
récemment
recently
devenus
became
éligibles à la
eligible for
vaccination,
vaccination,
48
with
d'entre eux
48%
ayant
having
reçu
at
une
least one
dose.
dose.
Au total, il y a
All
plus de
told, there are currently more than
6,5 millions de Canadiens
6.5 million
présentement
Canadians
admissibles
who
à
are
la
eligible but
vaccination
are not
qui
yet
ne sont pas encore
vaccinated
vaccinés
or have
ou qui ont
less
reçu
than
moins
2
de 2 doses
doses
de
of
vaccin contre la
COVID-19
COVID-19.
vaccines.
Slide 9. In terms of additional doses, 11 million COVID-19 vaccines third doses have been given, the majority of which are booster doses. While we are making progress in updating protection for those in higher risk groups, including older adults, we need to continue efforts to increase vaccine coverage to enhance protection for everyone we can. As seen in this chart, a considerable proportion of Canadians who have received at least 2 doses still need an additional dose to restore protection that may have waned since completing their primary series.
Diapositive 10.
Slide
Le
10.
fait d'être entièrement
Being fully
vacciné, ayant reçu
vaccinated
au
with
moins
at
2
least
doses
2
de vaccin,
doses
continue d'offrir
continues
une
to
bonne
provide good
protection
protection from
contre les
severe
maladies graves
illness requiring
nécessitant
hospitalization.
l'hospitalisation. Dans ce graphique,
In this
la forme
chart,
de la
the
courbe de
shape
ces
of the
cas
curve of
hospitalisés chez les
hospitalized
personnes
cases
non
among
vaccinées
unvaccinated
concorde
people
étroitement
closely
avec
aligns with
l'incidence
overall
globale
incidence
des
of
hospitalisations
hospitalization during the
pendant la
rise and
montée à la
fall
chute de la vague
of the
entraînée par
Delta-driven
Delta
wave
et vers la
and
hausse
heading into the
d'Omicron.
Omicron
À
surge.
l'inverse, le taux
Conversely,
d'hospitalisation
the
des Canadiens
hospitalization rate for
vaccinés est resté
vaccinated
à un faible
Canadians
niveau
remained at a
tout au
low
long de la
level
vague
throughout
Delta
the
et
Delta
commence
wave
tout juste
and is
à
just
augmenter
beginning to
avec le
rise
début
with the
de la vague
onset of the
Omicron.
Omicron
Il
surge.
est important de
It is
noter que
important
selon
to
les données
note that
d'hôpitaux
based on selected
sélectionnés jusqu'à la fin décembre, la majorité des adultes
data up
hospitalisés
to the end of
avec la
December, a
COVID-19
majority of
étaient des
adults
personnes
hospitalized with
atteintes d'une maladie
COVID-19
grave
were people with
liée à la
severe
COVID,
COVID-related
tandis que
illness,
jusqu'à
while
un
up to a
tiers ou
third
plus
or
avec le
more
COVID-19
with
étaient admis
COVID-19
pour
were
d'autres
admitted
raisons.
for other
Néanmoins, ces
reasons.
tendances montrent clairement
Nevertheless,
que le
these
fait
trends
d'être
clearly
vacciné
show
avec 2
that
doses
being
ou plus
vaccinated with 2
offre
or
une
more doses
protection
is highly
élevée.
protective.
Du début
From
novembre
early
au début
November to
décembre,
early December,
lorsque Delta
when
était
Delta
toujours le variant
remained the
prédominant au
dominant
Canada,
variant in
les
Canada,
personnes non vaccinées étaient
unvaccinated
19
people
fois
were
plus
19
susceptibles
times more
d'être
likely to be
hospitalisées.
hospitalized.
Alors que l'administration des doses
As booster
rappels se
doses
poursuit,
continue to
être à jour avec
expand,
nos
being
vaccins
up to
contre
date
la
with
COVID-19
COVID-19 vaccines
devrait
is expected
préserver
to
cet
preserve this
avantage
protection
de
advantage.
protection.
Slide 11. This updated longer-range forecast shows how the Omicron wave could evolve in the coming weeks as cases continue to accelerate across the country. It is important to note that this trajectory estimates the true number of daily cases as opposed to reported cases that may be occurring in Canada each day. Due to constraints on testing capacity, these numbers are much higher than can be detected. In fact, exceeds the number of cases reported in the surveillance data, shown here as orange dots. The 2 scenarios shown on the slide, both of which incorporate the impact of booster doses, suggest that the Omicron variant could cause a large wave that may peak in January and then recede into February. However, it's important to remember that these are modeled scenarios and the timing of the peak is likely to vary across the country. The red line trajectory shows that without recent strengthening of public health measures in many jurisdictions, the Omicron wave could have peaked at about 300,000 actual daily cases. Whereas the blue line trajectory shows that with the recent implementation of stronger measures, we could experience a peak that is lower, with about 170,000 actual daily cases. These scenarios highlight that while combined public health measures and booster doses could help reduce the size of the Omicron wave, in either scenario, the true number of daily cases driven by extremely high transmissibility of the Omicron variant could still vastly exceed anything we have experienced to date during this pandemic.
Diapositive 12.
Slide
Cette
12.
nouvelle prévision modélisée
This
portant sur les
updated
nouvelles
modeling forecast
hospitalisations
looks at
quotidiennes
predicted new
prévues
daily hospital
nous aide à
admissions to
comprendre
help
comment
us
la hausse
understand how
exponentielle
the
des cas
exponential
pourrait
rise in
affecter
cases
notre
could
système de
impact our
santé au
healthcare
cours des
system in the
prochaines
coming
semaines.
weeks.
En supposant que le nombre de
Assuming that
cas
the number of
d'Omicron
cases of
suivra la
Omicron
trajectoire
follows the
de la
lower
ligne
trajectory
inférieure
from the
de la
previous slide,
diapositive précédente, compte tenu de la mise en œuvre récente des mesures de santé publique dans de nombreux endroits du pays, cette prévision montre les deux trajectoires possibles concernant les nouvelles hospitalisations quotidiennes. La trajectoire de la ligne jaune foncé supérieur montre l'impact potentiel sur les hospitalisations si le taux d'hospitalisation pour Omicron était aussi élevé que Delta. La trajectoire de la ligne bleue inférieure montre l'impact potentiel si le taux d'hospitalisation était de 40% celui de Delta, conformément aux preuves émergentes d'une réduction de la gravité de la maladie au Canada et à l'étranger. Ces scénarios portent à croire que même si nous suivons la prévision plus faible concernant le nombre de cas et le taux d'hospitalisation nettement inférieur du variant Omicron, les nouvelles hospitalisations quotidiennes pourraient tout de même dépasser les pics historiques représentés par la ligne tirée horizontale verte en raison du grand nombre de cas qui pourraient survenir. Il est important de souligner que cette prévision ne reflète que les nouvelles admissions quotidiennes à l'hôpital pour la COVID-19 et non le nombre total de personnes hospitalisées avec une maladie liée à la COVID-19 lors d'une journée. Mais quoi qu'il en soit, nous nous attendons à ce que le nombre d'hospitalisations quotidiennes constitue un lourd fardeau pour le système de santé au cours des prochaines semaines.
Slide 13, experiences of other countries that also experience an Omicron surge provide additional insights into how the pandemic may evolve in the weeks to come. Countries like the United Kingdom and United States that experience a sudden and very steep rise in Omicron cases also experience a sharp rise in hospitalizations. However, given the lower severity profile of Omicron, hospitalizations haven't increased at the same explosive rate as cases. Nevertheless, the sudden acceleration and enormous volume of cases associated with an Omicron surge puts an intense strain on hospitals over several weeks and adds to longer lasting impacts, such as extended backlogs and strained workforce. With early signs that the surge in cases and hospitalizations may have peaked in parts of the US and UK, it is hoped that the heaviest impacts will soon be over in these countries. Likewise, if Canada's trajectory continues to follow a similar path, we are hopeful that cases will soon peak.
Diapositive 14.
Slide 14.
Alors que le Canada pourrait atteindre un pic prononcé suivi d'un déclin du nombre de cas dans les semaines à venir, étant donné que l'activité de la maladie dépasse de loin les pics précédents, même la descente de cette courbe sera considérable. Avec plusieurs semaines d'activité très intense attendues, nous devons faire de notre mieux dès maintenant pour limiter l'ampleur de la flambée d'Omicron afin de préserver les systèmes de santé et les fonctions critiques de la société. En pratique, nous devons continuer à, premièrement, être à jour avec nos vaccins contre la COVID-19, y compris recevoir une dose de rappel lorsqu'on est éligible. Les vaccins ARNM, Pfizer-BioNTech ou Moderna sont efficaces comme dose de rappel, alors ayez confiance en acceptant le vaccin qui vous est proposé. Deuxièmement, limitez les contacts personnels aux membres immédiats de même résidence dans les mesures que possible et finalement, utilisez systématiquement des couches de protection personnelle pour réduire les risques d'exposition et de propagation du virus. En suivant les conseils locaux de santé publique, portant un masque facial de bonne qualité et bien ajusté et maintenir une bonne ventilation. Merci. Thank you, Miigwech.
Thank you. Merci, Miigwech.
I'm just going to repeat the last slide, slide 14. So while Canada could see a sharp peak and decline in cases in the coming weeks, given disease activity far exceeds previous peaks, even the downside of this curve could be considerable. With several weeks of very intense activity expected to come, we need to do our best now to limit the size of the Omicron surge in order to maintain the health system and critical functions of society. Practically speaking, we need to continue to, 1, get up to date with COVID-19 vaccines, including getting a booster dose when eligible. Either the Pfizer-BioNTech or Moderna mRNA vaccines are effective as boosters, so please feel confident in accepting whichever vaccine is offered to you. Secondly, limiting in-person contacts to immediate household members as much as you can. And thirdly, consistently use layers of personal protection to reduce the risk of exposure and spreading the virus by following local public health advice, wearing a good quality and snug-fitting face mask, and maintaining good ventilation. So thank you. Merci, Megwidge. Happy to take questions.
Oui, donc on va passer aux questions.
So
on a environ jusqu'à midi 30 au maximum. Donc, opérateur, c'est à vous.
Maximum. Operator, up to you.
Thank you. For questions, please press star 1 on the device's keypad. Pour toute question, faites étoile 1 sur votre appareil. La première question nous vient de Raymond Filion, TVA.
The first question is from Raymond Filion from TVA.
Merci, bonjour. Je me demandais si avec la progression d'Omicron combinée à la vaccination, est-ce que ça pourrait permettre au Canada d'atteindre l'immunité collective et si oui, à quel moment Omicron pourrait devenir endémique?
When would Omicron become endemic?
Merci pour la question. C'est un peu plus compliqué que ça parce que avec Omicron et les autres variants du virus, on sait peut-être pour Omicron, on peut avoir peut-être une certaine immunité pour un bout de temps, mais peut-être que ce n'est pas une protection contre les autres variants, les autres souches du virus. Donc, ça peut aider un peu pour un bout de temps, mais ce n'est pas vraiment à long terme pour la comédie immunité collective. Donc, aussi avec les vaccins, on voit que les vaccins continuent à être très efficaces pour se protéger contre les maladies graves, mais peut-être pas comme par exemple avec le variant Omicron, contre comme dit l'infection et la transmission communautaire. Donc, c'est difficile à dire quand on va peut-être atteindre comme dit une immunité collective. Je pense que c'est toujours une question de combiner tous les outils à notre disposition, les vaccins, mais aussi avec toujours les bonnes couches de protection, les mesures de santé publique, aussi la protection individuelle. Et je pense qu'on va voir dans les semaines et mois à venir qu'est-ce qu'on doit faire pour trouver un équilibre, comment on peut comme dire, avoir le bon fonctionnement de la société avec un certain niveau de transmission et aussi peut-être on peut dire morbidité et mortalité dans la population. On peut accepter avec toutes les mesures et aussi les outils à notre disposition.
So to do this, we need to use all of the tools at our disposal. Thank you.
Oui, en suivi, j'aimerais parler de la dose de rappel, la troisième dose. Selon vous, est-ce qu'il faut l'administrer aux gens qui ont contracté la COVID-19 dès la fin de leurs symptômes ou c'est préférable d'attendre? Certains parlent de 3 mois. C'est quoi votre position là-dessus?
C'est une bonne question. On sait que notre comité consultatif national de l'immunisation est en train d'examiner toutes les données probantes et les expériences ici au Canada, mais aussi à travers le monde. Et ce que je peux vous dire maintenant, c'est qu'on sait qu'avec une infection, par exemple avec Omicron, ça donne une certaine protection, immunité contre le variant Omicron pour un bout de temps. Mais on ne sait pas exactement c'est quoi la durabilité de la protection, l'immunité contre une certaine variante, par exemple Omicron. Donc, je pense que si on veut donner une dose de rappel, on veut donner avec un intervalle, peut-être le bon intervalle pour avoir assuré la meilleure protection et l'immunité robuste et durable. Moi, personnellement, je pense avec ce que je connais, on peut peut-être attendre quelques semaines après une infection avec le variant Omicron, mais j'attends aussi vraiment les recommandations des experts dans notre comité consultatif pour leurs recommendations avec c'est quoi peut-être l'intervalle optimal après une infection pour avoir une dose de rappel. Merci.
To get a booster shot after an infection. Thank you.
Thank you. Merci. The next question is from David Thurton, CBC News. Please go ahead. Your line is open.
Hi, yes, good morning. How do you model for COVID, Dr. Tam, when not everyone can get a PCR test? Is it a challenge, and how do you do it?
Yes. So on a local level, it is challenging because not everybody can get a test. But we are doing a lot of testing in the country. So, for example, some of the initial slides, you will see that over 150,000 tests are being performed from a laboratory testing perspective, which is a good number for the purposes of tracking trends. So we've reintroduced a slide on the laboratory positive rate. And that can be one of the indicators, along with others, that we use to see where this wave is heading. Right now, we're in a slightly sort of gray zone, if you like, of waiting to see what happens next. You can't tell whether you've really reached a peak, for example, until after the peak is truly over. And so I think in interpretation of the graphs that we're showing today, I just caution that last part of the graph, data that could be incomplete. And so we need to wait a little while to see if the trend continues on the downward trajectory. And as I've said, it's different in different parts of the country. But I think we're doing enough to appreciate the trends. But obviously, at an individual level, not everyone will know for sure whether they got Omicron. But the other rule of thumb we're telling people is that if you had your symptoms somewhere after December the 20th or thereabouts, you probably got Omicron, and essentially consider yourself in that group.
Okay, I'll just follow up because you mentioned that it's very hard to tell when this wave has peaked until it has peaked. We are hearing from Quebec's Premier, François Legault. He said that Omicron has peaked in that province. Is there any data that you've come across to support that statement?
Yes, and I think you can see a number of charts even in our data at the national level, which is a composite picture. So Quebec will have more information at their level. But first of all, most likely you'll see the cases peak first before the hospitalizations and the ICU admissions. So you're seeing that pattern in the national picture. So the national picture is because Ontario and Quebec drives the national curves, given the size of the population, and they were the first to experience this Omicron surge. That dip in the case curve is perhaps indeed the trend, but we just have to wait a little while to be able to confirm that. The other thing is that even if a curve comes down, it can always go up again, depending on the contacts within a population. For example, as people go back to school and work, those cases could come back. So it won't be necessarily a smooth curve downwards. It could be a series of bumps. So we will likely be able to discern that at the national level as well.
Thank you. Merci. The next question is from Boris Pou, Le Devoir.
Boris Pou, Le Devoir. You have the floor.
Bonjour, ma question porte sur la diapositive numéro 12, c'est-à-dire sur les hospitalisations prévues. Dans votre présentation, vous parlez beaucoup au futur ou au conditionnel. On pourrait voir une hausse, mais si je me fie au graphique, en fait, on présente la situation entre janvier et février. Donc, aux dernières nouvelles, on est en plein au milieu de ça et on est exactement au pic qui est présenté dans ce graphique. Donc, j'aimerais savoir si, effectivement, on constate en ce moment qu'on est dans le scénario bleu, c'est-à-dire dans le scénario où le taux d'hospitalisation est diminué par rapport au variant Delta, mais qui dépasse le maximum des nouvelles admissions hospitalières.
That exceeds the highest hospitalization
Merci pour la question. C'est toujours difficile parce qu'avec la modélisation, c'est toujours, comme dire, c'est basé sur les données qu'on a actuellement. Et c'est pas comme une boule de cristal parce qu'on contrôle son propre destin. Et donc, je pense que si on continue avec la tendance, peut-être avec les mesures de santé publique en vigueur aussi, avec une bonne augmentation de couverture vaccinale, c'est toujours possible. Après, peut-être un déclin des cas signalés, que toujours comme dit, un indicateur tardif, on va voir un impact des taux d'hospitalisation. Donc, je pense, d'après moi, c'est peut-être trop à prononcer exactement qu'est-ce qui va se passer où on est actuellement. C'est toujours une question de suivre étroitement les dernières probantes et les cas, mais aussi les taux d'hospitalisation aussi, même les admissions aux soins intensifs pour voir c'est quoi les impacts sur le système de soins de santé.
Donc, si je comprends bien votre réponse, ça prendrait une boule de cristal même pour voir la situation actuelle des choses, d'accord? Je vais tenter une réponse très précise, une question très précise. À Montréal, on dit, ou au Québec, on dit que le pic est passé de hausse des cas, c'est-à-dire on a atteint en ce moment, peut-être dans les prochains jours, le pic de la hausse des nouveaux cas de COVID-19. Est-ce qu'il y a une crédibilité selon vous? Est-ce que votre scénario confirme un peu cette prétention?
OK. Sûrement peut-être pour répondre aussi, on n'a pas une boule de cristal. Personne n'a une boule de cristal parmi les autorités de la santé publique. Moi, c'est difficile pour moi de prononcer qu'est-ce qui se passe actuellement au Québec, parce que c'est sûr que les autorités de la santé publique au Québec ont les données les plus, comme dit, précises à comparer ce qu'on a reçu ici à l'échelle nationale fédérale. Donc, si les autorités de la santé publique à Montréal et au Québec voient peut-être qu'avec les tendances que les cas signalés commencent à diminuer, peut-être qu'on a peut-être dépassé le pic. Oui, c'est possible que oui, on va voir dans quelques semaines aussi un déclin avec les taux d'hospitalisation aussi, parce qu'on sait que normalement, si les proportions des personnes atteintes avec la COVID-19 vont continuer à avoir, comme dit, auront besoin d'hospitalisation. C'est peut-être optimiste de voir avec un déclin des cas signalés. Si c'est vraiment une bonne, comme dit, une bonne tendance, si ça continue, peut-être on va avoir un impact. Mais pour moi, c'est difficile à prononcer et c'est mieux de vraiment aller aux autorités de santé publique de Québec.
Thank you. Merci. The next question is from Abigail Beeman, Global News. Please go ahead. Your line is open.
Hi there. Thanks for taking my question. As you note, several provinces are starting to give more detailed data on hospital admissions. Using Ontario as an example, we now know nearly half of people included in COVID hospitalizations were actually admitted for another reason but tested positive. I'm wondering if this is the first time you're including that national look of people who were admitted to hospital because of COVID versus for another reason. What benefits or drawbacks do you see in this kind of reporting? And also, does it suggest hospitals may be less stretched compared to a non-COVID regular year now that we have this additional information?
Yes, Teresa Tam. So as you said, many jurisdictions are now trying to discern whether someone is hospitalized because of COVID or that they also have COVID and they're admitted for something else. I think that's useful in the study of the impact of the Omicron variant, but for the hospitals themselves, they are pretty full, and hospitals have always been very stretched during the winter months in any case. And so this really doesn't help at all, having a massive Omicron surge. What I'm seeing is that even if you say, so think of only a proportion of cases in the hospitals directly because of Omicron, the numbers that I'm seeing of hospitalizations being reported, even if you have that, it's still much higher and getting that to be higher than the other peaks that we've seen in the other waves. That's just the comparison. So even if only a proportion of them are there because of Omicron, it's still a huge number of cases. the other parameters that we are trying to discern from the provinces is the length of stay and then also the clinical progression inside the hospitals. So far, what we've been hearing is that the length of stay seems to be shorter for the Omicron variant cases that we're seeing after December, and also that for the ICU admissions, there seems to be less of those, but still over 884 daily critical care bed use is huge. So that, I guess the bottom line is this variant is having a very significant impact on the hospitalizations. But the other thing that's very different is that, of course, staff are getting sick at the same time. So that is putting a lot of pressure on the hospital systems.
It's Dr. New. Maybe I could just add one additional point, and that's the fact that, we are teasing out with obviously our counterparts in the provinces and territories in terms of hospitalizations. They say, because of COVID-19 or sort of just an incidental finding if someone sort of went to hospital for another reason, maybe elective surgery and so on. But the bottom line, really, if you're on the ground, is that it still has a tremendous impact in terms of the strain on human resources, because if you do find it as, quote, an incidental finding, someone with COVID-19 in the hospital setting, the staff, et cetera, you have to take other precautions and the measures, et cetera, to try to prevent, obviously, onward spread. So, like I say, even if, it's not a direct impact in terms of having to deal with a COVID-19 case that is in there because of serious consequences because of the virus itself, there's still obviously a knock-on effect in terms of the impacts of just finding, the COVID-19 the virus with other admissions to the hospital. So overall, as we've been repeating, the strain on our healthcare system is tremendous. And I think as much as we can do, all of us individually, collectively, to decrease the pressure on the hospital system, our exhausted healthcare workers on the front line, I think that's really what we need to be focusing on. Thank you.
Thanks, that's really helpful. I also wanted to ask about the information in your notes about children, infants being 7 times more likely to be hospitalized than children under 5. I'm wondering if you can shed more light on what we know about infant and under 5 hospitalizations. Is this higher or different than in previous waves? And also, do we know whether these infants and young children, generally speaking, have other underlying conditions?
Yes, thank you for the question. So the rates are still low in children, but because of the massive number of cases in our communities, we do expect the actual numbers to be higher than in preceding waves. So I think that was expected, but the absolute numbers are still quite low. We've been checking in with a network of all the pediatric hospitals to ask them what they're seeing. And so in general, the cases are not very severe, but of course severe enough to be hospitalized. Infants, no matter what respiratory virus you get, are likely to be more severely impacted. And so I think that's not unusual. So any infants under 1 year of age often experience more severe outcomes from respiratory viruses. So there's a number of, I think, important things to consider for kids, of course, to protect younger children, especially because they're not eligible for vaccines. The adults around them and the guardians need to up the game in terms of getting themselves protected through vaccinations and boosters and masking and all the other layers of protection to protect them. But one other really important point to make is vaccination during pregnancy. So this is very important for protecting the individual who's pregnant, but also the infants, both of whom are at a high risk of severe outcomes. So vaccination with a mRNA COVID vaccine is strongly recommended, and research shows that vaccination during pregnancy triggers the development of protective antibodies that can also be passed on to that young infant and provide that infant with a level of protection.
Thank you. Merci. The next question, la prochaine question est de Raphaël Pirot, agence QMI. À vous la parole.
Raphaël Pirot, agence QMI.
Oui, bonjour.
The floor is yours.
Écoutez, je veux vous demander par rapport au programme de collecte de données de géolocalisation.
I would like to ask you about the geolocation data collection plan.
Qu'est-ce que la santé publique fait?
I would like to know what public health is doing with this data. Specifically, why are geolocation data collected for modeling?
OK, merci pour la question.
Thank
Moi,
you
je
for
peux
the
commencer.
question.
Peut-être Dr. Tam a quelque chose à ajouter. Premièrement, je peux vous dire que on prend vraiment pour les sérieux la confidentialité, la vie privée des individus. Ça, c'est très important. Ce qu'on collecte, c'est toujours avec les données, c'est toujours à l'échelle de la population. C'est pas vraiment pour les individus. Et c'est notre comme outil pour aussi pour aider à évaluer, montrer c'est quoi les mesures de santé publique. Est-ce que ça peut aider pour peut-être indiquer peut-être si le taux des cas peut-être peut augmenter, peut-être lié avec le taux de mobilisation, les mouvements de la population. Ça, c'est en général, c'est une aide, mais c'est toujours pour assurer que c'est jamais avec notre collecte de données à l'échelle des individus.
That our data collection is not individual personalized data.
Merci. Et deuxième question.
Thank you. Second question on another subject.
La santé publique
in Spain,
lancé un appel à
public health
traiter la vague d'Omicron une fois que le pic sera passé comme
put
une
out a call for
normale. Donc,
Omicron to be considered a regular
la santé
flu.
publique là-bas propose.
That's what I'm understanding public health there is proposing. People are reacting strongly. Could we say the same thing here in Canada? What do you think of that?
Et on parle toujours évidemment à la fin de la vague Omicron.
We're talking about
le pic sera dépassé.
Saying this after the peak of Omicron has passed.
Merci pour la question. Je pense que c'est un peu tôt pour prononcer est-ce que c'est semblable à ce qui se passe avec le variant Omicron et le COVID-19 en général comparé à la grippe, l'influenza. On voit maintenant actuellement avec le taux d'hospitalisation, avec la morbidité, mortalité, que c'est vraiment il y a beaucoup de pression sur notre système de santé. Donc, je pense après, peut-être on espère après la vague d'Omicron, on va voir qu'est-ce que c'est quoi les prochaines étapes avec la vaccination, avec toutes les mesures de santé publique. C'est quelque chose, on va toujours suivre la science et les données probantes pour avancer à les prochaines étapes. Qu'est-ce qu'on va faire ici comme une société? Mais pour l'instant, on est encore dans le feu d'action, on peut dire, et c'est quelque chose, il faut réagir maintenant avec la situation actuelle et on va voir après qu'est-ce qu'on va faire avec tous les outils disponibles pour combattre contre le COVID-19.
Thank you. Merci. The next question is from Marika Walsh from the Globe and Mail. Please go ahead. Your line is open.
Hi there. Thanks so much for taking our questions. I wanted to go back to what Boris was asking earlier about the peak, because looking at the slides, it quite clearly shows the wave that's being projected and modeled is that we're essentially in the peak now. We're about to hit the peak for hospitalizations, and that we've already hit the peak for cases. And then the slide title says a surge is coming in the next week. And so I'm just confused about what you're saying. I understand that you can only say with certainty that we've hit the peak after it's over, but it seems to be showing based on the data that you actually do believe that we are now at the peak based on available data. Is that correct or is that incorrect?
It's Teresa Tam. I'll take that question. I think the next week is actually quite important. We received a number of questions today about, well, in certain local areas, have they reached a peak? What about Quebec? I think a number of provinces, the biggest ones, put it this way, who have particularly experienced the Omicron surge the earliest, are seeing some stabilization at a very high level, but some stabilization in the daily case rates. So I think this is the early signal that we could be approaching that peak. All I'm saying is that there's a gray zone or a zone of uncertainty that you're seeing in either the projections, but also in the actual case trends. So I think come back in about a week, we'll probably have a little bit more information as well. But it is quite possible that in the next days that we'll see that, peak at least in the cases, the hospitalizations. What I would say is that what the modelers did is that they inputted certain assumptions, like how many days after a case declares itself would they get hospitalized. Those assumptions may or may not be completely aligned with reality and the range. So you're seeing that uncertainty being depicted. I think the models are there to, I guess, assist with planning purposes in terms of whether it would exceed previous hospital intake. And so I think all of this, though, does align together with the international data to say that we could be like others, seeing a sharp increase and then it coming down fairly fast. But I think we're all just wanting to be a bit cautious about pronouncing on that until we've seen more information.
Okay, thank you so much for clarifying that. I also wanted to go back to your comments at the beginning where you said that if you had symptoms on or after December 20th, assume you had Omicron. Earlier this week, we saw Alberta say that they believe their actual case count is 10 times higher than the reported number. What is PHAC's estimate of the true case count in Canada? Is it 10 times higher across the country, or what is the sort of guesstimate that you are working on?
Well, I think if you see one of the forecast curves, you see those little orange points. It's the actual number of reported cases through surveillance. Our previous models, the little red dots or other plots that we've had followed the projections pretty well, and now it doesn't really. So I think the number of cases are likely to be much higher. But it could be different in different provinces. We've seen that even with the other waves where in fact, Canada was quite good at capturing most cases, and we backed it up through sero surveys where we look at antibody levels. Yes, you only get the tip of the iceberg, but we got quite a large tip of the iceberg compared to maybe some other countries. Right now, I can't tell you at the national level what that means. I think the sero surveys that will be conducted over time, particularly, I think at the end of this wave, will tell us maybe how much of the population did get infected in the end. But I do think that it could be different in different jurisdictions, and some of it might depend on their capacity for testing at any given moment.
Thank you. Merci. The next question is from Alex Ballingal, Toronto Star. Please go ahead. Your line is open.
Hi, thank you very much. Just on testing, we've heard from some experts questioning whether, given the prevalence of Omicron, testing capacity in the provinces, how we don't know the actual true number of cases, that it's making less and less sense to put so much resources into testing incoming travelers. So I wonder, Dr. Tam, what you think about that. Is this Omicron wave different, and does it still make sense to put, I don't know what the budget is, I think it's $600 million towards testing people coming into the country?
Yes, so as you say, in the domestic sense, tracking every case isn't really necessary for a surveillance perspective, but while it may be important for certain individuals, I think at the border, it's not just Omicron-related detection that we are trying to do. Is we're there also to detect any other new variant or mixes of variants. But at the moment, when the whole world has Omicron, our next door neighbor has Omicron for the most part. You're right in that we could do sampling for the tests instead of testing maybe every single vaccinated individuals coming from other countries. But we will evaluate that over time. It is a capacity drain on the systems as a whole. So we've been trying to look at that and balance it out. At the moment, of course, we are continuing the trajectory that we have laid out in terms of traveler testing, but we should evaluate that over time. But what is really important for the border is a really good random sample where you are not just following Omicron, but following the other variants.
So just to clarify, so have you brought that up in your advice that this is maybe something where the resources being put to use could be better utilized elsewhere? Is that something that you guys are actually looking at, changing that practice?
I think we're always evaluating this with our laboratory colleagues, and we haven't as yet had to make a shift. But if necessary, I think we would consider it. There is, I think, for the sequencing though, it is something that we are looking at because you don't have to sequence every case anymore. It is all Omicron. So we were sequencing every single traveler. We don't think that is actually needed or viable. The genomics capacity can be utilized in different other ways. There's also staff absenteeism and other things. So I think my advice would be not to have to sequence every single traveler case.
Thank you. Merci. The next question is from Ryan Tumulty, National Post. Please go ahead. Your line is open.
Yeah, I'm wondering, Dr. Tam, you talked a little bit about estimates of how much the cases actually exceed the publicized daily case count and some of the other assumptions that you are making. I'm wondering how you're making those assumptions. Why do you assume that the case levels are that much higher than the testing? What data is driving you to that conclusion, I guess?
Well, I think partly it's just the indication from our colleagues, the other chief medical officer, that they're simply not able to test every case. So you know that to be true. That's a fact. And also anyone who did a rapid antigen test, for example, that's not captured through for the most part. Some jurisdictions are trying to do so, but a lot of it is not captured through the provincial system. So we know that we're missing that part of the part of the iceberg, if you like. So, and as you've seen from the reports from the other chief medical officers, they're quite clear that they're not going to track every case. We've moved on from individual case contact management as soon as this resurgence became very significant. So you don't need that for the population level management. You're moving towards the broader messaging, and you can't trace every contact, etc. So we know that to be true. And even with the other ways, as I said, in retrospectively looking at the serologic surveys, we know that we only detect the tip of the iceberg. Now the lab testing capacity, rightly so, is directed towards those most at risk. And it would be very important, of course, to direct things like treatments. People are looking forward to antiviral treatments, for example, and you need to make sure that the tests are directed towards those. So there is no doubt that we underestimate the cases. Having said that, though, our focus of attention should be more looking at the hospital trends and the severity indicators. The case trends gives you a signal because it's the earlier signal than the lagging indicators. But really, we have determined, and I think there's a slide that shows you the characteristic of the Omicron virus, one of which is that, really you want to be tracking hospitalizations, ICU admissions, because that is where our public health action and healthcare action is going to be. And also that the vaccines themselves. The most important aspect of the vaccine effectiveness is tracking its effectiveness against severe outcomes.
I guess just as a follow-up on that, I guess I'm sort of wondering, though, how I understand that cases are definitely higher than what's being reported. I'm wondering, though, how you estimate how much higher, and how you mentioned at one point that you think there may be, at the peak of the wave, somewhere around 170,000 cases a day. I'm just wondering, how do you decide what the multiplying factor is there?
Yeah, and I think there's different models being used, and some of the details might be in the annex, but some of it is taken into account other parameters such as transmissibility, the R value that you've all got a bit used to, and comparing Delta to Omicron and factoring some of those elements in, as well as there's many other injects into those models, including booster dose uptake, etc. So I think it's quite a complex, composite of inputs in order to generate those curves. But those are the estimates that's been generated by the modelers to give people a bit of an idea of how high those case counts could be.
Thank you. Merci. The next question is from Laura Osman, the Canadian Press. Please go ahead. Your line is open. Once again, Ms. Osman, you might be on mute.
Pardon me. Sorry about that. Thanks, doctors. I wanted to ask you about the data. Dr. Tam, you said that tracking every case isn't necessary for good surveillance necessarily, but it's clear that from slide 5 that we're losing some of the more granular data. I'm thinking particularly of data involving how much this is impacting kids. A lot of the public health measures are disproportionately affecting kids. Schools are closed, recreation is closed. And so how do you make good decisions, and what are your fellow chief medical officers saying about how you make decisions about whether or not these measures are working when the people they affect most are not being tested?
And I think there is a lot of testing, and there's probably enough testing to look at those trends. So you can see the disaggregation by age and how those are trending, and the shifts over time between the younger adults, and then really the spread of the cases into the other age groups. So that is actually quite easily detected and can be trend using surveillance data at this point. We're doing like 1 million tests a week, over 150,000 a day. So that I think presents a reasonable data set. But we do pay attention when the policies suddenly shift. And that's why I think looking at the composite of all the different indicators is important. The other thing is ultimately the hospitalization rates are important to track. And those tend to be, quite comprehensive in terms of the numbers of hospitalizations, so that you can have a greater certainty about. I think that this aggregation that's happening to further understand who is being hospitalized because of COVID, who is having their underlying medical conditions being made worse as a result of COVID, are all very important. But it is quite easy for us to use hospital surveillance networks to trend the hospitalizations in pediatrics and the pediatric ICU admissions, for example. So I don't think we will lose track of the ability to detect any significant change in those parameters.
Thank you. On hospital cases, nurses have flagged that the number of people in hospital with COVID who are there for other reasons may be reflecting in-hospital transmission, and they're really concerned about that. Is that something that you're seeing in the data, something that you're particularly concerned about?
Yeah, so again, I think the details will have to be obtained from the local jurisdictions. But yes, there's in fact different categories of cases that are hospitalized, some of whom actually did acquire COVID as part of a acute care outbreak. So those are happening. Those outbreaks are being tracked. And it could be due to a number of factors, sometimes as to what the dynamics are in terms of the spread in healthcare settings. But it really does continue to stress the need for good infection prevention control practices. But it's been very, very difficult. I mean, I think healthcare workers, no matter how hard they try, like the rest of the population, in minimizing their risk, this is such a transmissible virus that we have to all up our game everywhere, including mask wearing, etc., ventilation and everything else in order to reduce those risks. So, but yes, healthcare setting related outbreaks are something that we should do everything to try and minimize.
Thank you. Merci. La prochaine question est de Marie Chabot-Johnson, Radio-Canada.
Marie Chabot-Johnson from Radio-Canada. You have the floor.
Merci.
Thank you.
Si on n'est pas capable encore quand même de dire qu'on atteint le sommet de la courbe,
if we're still unable to say that the peak has been reached for Omicron, I understand we're still uncertain about the data.
Tout de même essayer de garder les mesures sanitaires en place le temps qu'on sache si on est passé la courbe.
Public health measures until we have a better idea.
Comme au Québec qui ont décidé d'enlever le couvre-feu, par exemple.
There are places in Quebec, for example, that have removed the curfew.
C'est Dr. New. Merci pour la question. J'ai
This
peu
is
de
Dr.
difficultés à peut-être entendre avec un peu d'écho, mais si je comprends bien, c'est toujours oui, ça c'est l'enjeu actuel pour les autorités de la santé publique et les décideurs dans chaque juridiction comme le Québec. Il faut suivre les données de surveillance, mais aussi liées avec les mesures de santé publique. C'est pas pour moi pour prononcer qu'est-ce qui se passe au Québec avec leurs données et leurs propres décisions pour les mesures de santé publique. Vous avez parlé de couvre-feu. Ce que je peux vous dire, que je comprends qu'au Québec et dans n'importe quelle province et territoire, c'est très important de voir c'est quoi les impacts sur les taux d'hospitalisation comme un indicateur tardif. Mais aussi, c'est lié avec les cas signalés dans la province. Si les autorités, ce qu'on voit maintenant, voient que peut-être il y a un plateau ou peut-être le cas signalé commence à diminuer, peut-être un peu, lâcher quelques mesures de santé publique, mais c'est vraiment pour les décideurs à prendre des décisions comme ça. Et aussi, c'est toujours une question d'être flexible et s'ajuster comme nécessaire si peut-être la courbe épidémique commence à aller dans une mauvaise direction.
The epidemiological curve
changes direction. On voit bientôt le Canada va mettre en place sa politique pour bloquer l'accès aux camionneurs étrangers non vaccinés puis demander la quarantaine pour les camionneurs canadiens qui sont vaccinés. À votre avis, quel impact est-ce que ça va avoir sur la santé publique? Est-ce que ça va avoir un impact concret?
Can you tell us what the impacts might be on this?
Oui, pour moi, c'est toujours l'objectif pour la santé publique en général pour le Canada, c'est oui, on va augmenter notre couverture vaccinale le plus haut possible. Et les camionneurs qui sont les Canadiens font partie de notre population générale, de notre société. Donc, je pense que c'est très important d'encourager l'adoption des vaccins pour toute la population. Donc, on sait qu'il y a des enjeux, peut-être des impacts dans n'importe quel secteur pour accommoder l'infrastructure et aussi le fonctionnement de notre société. Mais je pense en général, je pense que pour n'importe quel secteur, il faut continuer avec tous les mesures, tous les outils, l'éducation, tout ça pour augmenter l'adoption des vaccins. Parce que c'est les données à date démontrent clairement
Current
que les
data is
vaccins sont
showing us
sûrs et
clearly
efficaces
that
pour la protection
vaccines are
des
safe
personnes,
and
mais aussi
effective in
pour
protecting people.
pour se protéger pas seulement contre la contamination, mais aussi contre les maladies graves.
And
Mais
vaccines
aussi,
protect us
c'est aussi
against
des bénéfices
contamination, but
pour
also
les
against
proches aussi
severe
des autres
illness.
personnes dans
It's
la
also a way
communauté.
of
Donc,
protecting
on
people
continue
around
avec nos
us and
efforts
our communities.
d'augmenter la couverture vaccinale en général.
So definitely, we aim to increase vaccination rates in general.
This question is for Dr. Tam. You've already mentioned a few times that healthcare systems across the country are having a very difficult time. New Brunswick brought in new restrictions today because of concerns about its own healthcare system really approaching a crisis. I want to know, in practical terms, what do provinces have to prepare for when they look at the forecast for hospitalizations, even at the low end here with, say, 2,000 cases of new hospital admissions daily? You know, are we concerned about overflowing or tapped out ICU resources? Are there enough, intubation and respirators? Let's say, you know, what practical impact will these forecasts have on healthcare systems across the country? What do provinces need to prepare for?
Yes, and we're obviously not the only ones doing forecasting. It's being done at the provincial and other levels as well. So it's always better to prepare and prepare ahead for the worst case scenarios. I think this is not the first time we're going through this, and it's very important to have approaches to look at how you can continue your acute care system. And many jurisdictions, of course, have tried reducing elective procedures, having surge beds, even building, additional beds and field hospitals, and all of that. It has been in their preparedness scenarios. That's already been done. Obviously, we've been looking at supplies. There's definitely enough ventilators. The ICU rate isn't going up as high as the hospitalization rates. So looking at that very carefully is important. We are sharing information on length of stay and that type of thing across the jurisdictions, because that's really important to know how long someone stays, because that has a significant impact on how you project your hospital capacity. So all of that information is being shared across federal, provincial, territorial tables to inform the provinces that might be coming a little bit later than the initial ones. So those have been, I think, the most practical ways of doing this. But the other thing is factoring in staff absenteeism. So I think that's almost the most difficult rate limiting step for jurisdictions right now. And as a result, they are doing more population-based measures to reduce contacts, because it's not just about getting enough beds, is about getting enough human resource and protecting the healthcare workers in their communities.
I'll just take a follow-up question here. Can you give us an estimated percentage of cases? I know that testing isn't exactly as widespread as it once was during this pandemic, but is it safe to assume that all of these new cases are Omicron, or is Delta still making up a percentage of the cases across the country, or even other variants?
Yes, so right now, we don't really need to sequence every single case. As I've said, you need a sample of them, and the vast majority are Omicron. At the same time, there's always a very small number of other genomic sequencing that we're detecting. But right now, the Omicron variant is absolutely the majority, and that is being seen in every jurisdiction now.
Thank you. Merci. The next question is from Dylan Robertson, the Winnipeg Free Press. Please go ahead. Your line is open.
Good morning, doctors. I'd like to discuss incidental COVID-19 in hospitals, as it seems that this is not being consistently reported by the provinces. Are you providing any guidance to medical officers on how to parse primary versus incidental infection? And is FAC recommending provinces do this analysis, or is the value of this data totally at the province's discretion?
It's Teresa Tam. So this is an actual technical area that we've discussed in our federal, provincial, territorial tables at the SAC and the chief medical officers and our technical groups. So provinces, it is definitely the most useful for the provinces. At the same time, at the sort of national level, it is still useful for us to know that parameter. I think that the difference between the Omicron and other variants is that it's just so pervasive that you could very well come in because of something else and you have Omicron. So that's the slight difference between this variant and others. And I think sometimes it does help with local level planning, but it's much more important for provincial levels. But we are sharing how the methodology, put it this way, of how provinces are trying to discern that difference. And the way that they try to disaggregate that information varies as well. And a lot of effort has been put in. Some of it is an actual manual case review. That's how much effort it takes to get at that information. Now, once you know, you have a bit of an estimate. I'm not entirely certain that it's worthwhile just keep doing it all the time, but that's up to the local jurisdiction to decide. But we are sharing the methodologies on how that is done. And as I've just said, some of it is also disaggregating the ones acquired inside the hospital as well.
Thank you. And Dr. Tam, certain provinces say it's up to individuals to protect themselves from COVID. They're abandoning attempts to limit the spread and instead focusing on avoiding the worst outcomes. But is it actually possible for everyone to protect themselves given the disparities that you've reported on in public health?
Yes, so getting equitable access to layers of protection is always a concern. So I do think that at the federal level, one of our roles is trying to, as I said, level the playing field as much as we can. So I think having social supports is important. Some of the policies in terms of supports to individuals at the lower socioeconomic strata or small businesses, and that's not within our realm of policy decision-making, but it is very important. And of course, one of the federal roles is to support Indigenous communities, and I believe Indigenous Services Canada had provided an update on some of those measures as well. We're also concerned about the distribution of rapid tests to those who may have needs but can't access. So through the Red Cross and mechanisms and other NGOs distributing rapid tests. And I actually think distributing good, high quality masks, for example, to populations experiencing equity disparities is actually important as well. It is, of course, certain workplaces. I think making sure that employees who have to be on site to work, unlike a number of us who can telework, is also extremely important, and making sure that they have everything that they need to protect themselves.
Thank you. Merci. The next question is from Wyatt Sharp from the Wyatt Sharp Show. Please go ahead. Your line is open.
Hi there. Just one question to start off as it relates to COVID treatment, specifically Pfizer's pill to treat COVID. Obviously, it's not yet approved by Health Canada. I'm just wondering, though, if it does get approved by Health Canada, what kind of an impact that will have on, for example, future modeling, like the modeling you presented today, what kind of an impact that could have on future hospitalizations, and if you even have a sense of that yet.
Yes, so for modeling purposes, it could be something that we can factor in. The benefits of Paxlovid, as demonstrated through clinical trials, is to reduce severe outcomes like hospitalizations in those at high risk. Those initial clinical trials were done in unvaccinated populations as well. Once we get a medication, trying to get some data on its impact post-authorization is important, and those kind of data will help inputs into models. So one might postulate that a model that estimates X number of cases could end up in a hospital. Well, if you had a treatment that could prevent some of that, that can potentially be factored in, but I think this is a little too soon. I think Canada is fortunate in being probably one of the first countries in the world to access these medications, but there is a global supply constraint. It may not be in widespread use for a while, so I'm not certain when that would be significant enough to factor into the model. But I think overall, if we do see the proportion of people who get COVID and you know, the rates of hospitalization, that's still an important indicator to trend over time for sure. But not just now, but I think later on it could be factored in.
And is there enough evidence yet to show you know, which people would best to give this treatment to? Because you just mentioned that if it does get approved by Health Canada, there will be limited supply of it. So is there any idea of, you know, once it does get approved, should be prioritized, or is that just, once again, something else that's kind of just remains up in the air up until it is approved by Health Canada, and if?
Well, I think we're trying to line up all of the different tools and supports provinces might need to help them with implementation. So I think what we're trying to do at the Public Health Agency is to convene experts to help provide some considerations as to how the initial supplies could be prioritized, much as we did at the beginning of getting our initial doses of vaccines. So that work is underway as well.
Alors, c'est ce qui met fin à cette conférence de presse. Thanks everyone for being with us. Thank you, doctors, for your time. Have a great weekend, everyone.
Thank you.